Welcome to the Hot Topics session, and I actually think it's very appropriately named because every single talk to follow is something that either bothers me, puzzles me, or I have no idea what to say when my students ask me, so what's going to happen? So I'll be looking forward to hearing these as much as anybody. In the interest of time and preserving a little bit of time at the back end for questions, I'm not going to try and wax real clever about all the speakers. I'm just going to tell you who they are, and then we'll actually have our talks. So the first speaker will be Kimi Kondo, giving us an update on what to tell med students about the new IR path.
So I'm going to be telling you about the latest in terms of the IR-DR dual certificate, because you really can't tell students about it if you don't know about it. So in terms of the learning objectives, I'm hoping that at the end of this you can explain the most current information regarding the new ACGME program requirements and the accreditation process. Although details for the accreditation process, unfortunately, I don't have many because they're not yet available. And then also describe the transition period from the current IR fellowship program to the new 3-2 format of the new residency. And then maybe just touch upon the impact that this new residency will have on radiology medical student education in terms of recruitment of students, as well as advising students who are interested in diagnostic radiology and or interventional radiology. So I just have some disclosures of, I own some shares. Anyways, I don't think it's quite relevant, but you know, you own shares of healthcare, they make you disclose them, whatever. Okay, so in order to know where we're going, it's important to know what we currently have going on. And so in terms of the current IR training requirements, it's a 6-year pathway, 1 year of internship, 4 years of diagnostic radiology residency, 1 year of fellowship. And in terms of certificates and board certification, the ABR has a primary certificate, as you're all aware, in diagnostic radiology. And then there's actually a certificate of added qualification or a subspecialty certificate in in vascular and interventional radiology. In terms of that certificate, it's a subspecialty certificate, and it kind of is important to understand what's the difference between specialty and subspecialty. Well, specialty is a distinct and well-defined field of medicine, whereas a subspecialty is going to be an area of focus within that specialty. So obviously, in order to sit for the CAQ, you have to be an ABR diplomat. You have to complete an ACGME accredited fellowship in interventional radiology. You also, during your fellowship year, have to have at least 500 cases, and within the first 12 months out in practice after fellowship, you have to have 200 cases. There is an oral exam, so it's like, hello, Louisville, here I come. And then your CAQ is actually a 10-year renewable certificate. It is not lifetime. In terms of the new dual certificate, this is actually the establishment of a new specialty, which has been approved by the American Board of Medical Specialties, or the ABMS, in 2012. So now IR is actually recognized at the same level as diagnostic radiology as a specialty. And it says that practitioners are competent not only in diagnostic imaging, but also in peri-procedural patient care as well as image-guided procedures. It's one of 4 certificates that are offered by the ABR, the others being, of course, diagnostic radiology, radiation oncology, and medical physics. And, you know, that's just the board certification process. In terms of training, the ACGME is in charge of training and has approved a new IR residency as of 2013. So what about this residency? Well, again, it's recognition that peri-procedural care is integral to IR practice. It allows for an additional year of training in order to master procedural and clinical domains. And it also allows trainees to come directly out of medical school. and not having finished a residency program before going into fellowship. But I think the important thing is that it maintains core competency in diagnostic radiology, and that's important to remember. You know, there is this greater focus on clinical care, but we haven't forgotten about that imaging competency in radiology itself. In terms of timeline, in February of this year, the RRC, actually the task force, approved a draft of the program requirements. And hopefully sometime this month, it's expected that those program requirements will actually be posted on the ACGME website, and that will be open for a public comment for 45 days. So it's important that everybody actually, and medical students as well, are going to be allowed to comment on this, and the RRC will actually have to respond to every single comment, okay? Yeah, it's going to be a big process. And, you know, there could be potential modifications of these program requirements as a result of that, or there may not be, who knows? So then it's expected that after this comment period and the response and everything, that there would be a review by the ACGME Committee on Requirements, and then hopefully sometime at the end of this year that then it would be approved by the ACGME Board of Directors. In terms of a working framework of these requirements, the first thing is that people will have a clinical internship. And this is a little bit different from, I think, what we were hearing last year. Last year they were talking that the internship would be a part of it. People were concerned, well, how am I going to all of a sudden fund interns when most programs today in diagnostic radiology don't include interns? Well, that won't be a consideration. So in terms of the residency, the first 3 years are the PGY 2 through 4 years, which is the R1 through 3 years, will actually be exactly the same as currently diagnostic radiology is today. The IR residents will still have to pass the ABR core exam. And then the PGY 5 and 6, or R4 through 5 years, would be those years that would be heavily IR related. They would see patients in an outpatient clinic. They'd have to admit and discharge patients to an admitting service. They would have critical care or ICU training. And in order to allow flexibility during this time, anywhere up to 4 actually rotation in diagnostic radiology would be possible during that time. And IR is not going away from an oral exam, so there still will be that oral exam. Importantly, there's going to be they're talking about 2 different types of program formats. One is an integrated, where the residents are going to be matched straight out of medical school, and the entire educational experience will be provided during residency, versus an independent program where residents can enter in at a later stage of their training and being given credit for the earlier training. And this is going to allow for maximum flexibilities of programs, and maybe this will help to fit institutional constraints at different places, while again achieving the same goals. Just to give you kind of a breakdown of the integrated program, so we're talking about 4-week rotations, DR, diagnostic radiology, IR, and then ICU. Again, this PGY 1 year is going to be the internship. It doesn't matter whether it's surgery, medicine, transitional, even pediatrics. And then 2 through 4 would be similar to what is currently going on in terms of diagnostic radiology. And then 5 through 6 would be kind of the intensive IR training. And in terms of during this time, it actually could be in IR-related rotations that may not necessarily be offered within the Department of Radiology. For example, medical oncology, hepatology, vascular surgery, those types of things that I think are very important to the practice of interventional radiology today, and having an understanding of that clinical context of especially the colleagues that we're working with and patient care. However, not all of the rotations can be in that, because there will still be a minimum requirement of the number of IR-related procedures that those people have to do. So in terms of entry into the IR residency, again, out of medical school, there would be a match where you'd come in at that PGY2 level. Again, this is a 3-2 format. So say you have a person who comes in, says, you know, I want to go into IR directly out of medical school. Well, you know, I think like a lot of residents today, how are they going to really know what they want to do in their future? So we have to allow a way for people to go back and forth. And so because the first 3 years are going to be exactly like diagnostic radiology, that, you know, if they decide, I don't want to do IR, I like something in diagnostic radiology better, they should be able just to transfer out. And at the same time, if you have somebody who all of a sudden discovered, I really want to do IR, they should be able to transfer in. The other thing is that, again, you might have somebody who could transfer in as a more senior level resident. They would have to meet certain prerequisites, for example, at least 12 months of IR or IR-related rotations and at least 500 IR-related procedures to kind of skip that PGY 5-year. But if you look at it, there actually, especially at the beginning, a lot of programs might have a blend, because no program that currently has IR fellowships is all of a sudden going to be able to have all their people starting at PGY2. So some programs, and especially I think at the beginning, they might say, okay, well, this is, if we have this qualified transfer, that'll be kind of what we already have in terms of the fellowship, and then we can kind of balance the number of people we have throughout the residency program, and it may not be as much of a burden. In terms of the independent programs, that would be something that, again, provides flexibility for those current fellowship programs that actually aren't necessarily tied to a diagnostic radiology residency, but have a very high-powered fellowship. And we wouldn't want to disenfranchise those programs because they don't have that relationship. So again, they could do a year of internship, 4 years of diagnostic radiology residency, and then come in at this 5th year. Or again, if they've met the prerequisites, they could actually come in and do that final 1 year. In terms of the timeline, the ABMS says you can't have both ways of the 1-year fellowship and the residency. So eventually the 1-year fellowship will go away, but it's going to be anticipated that there will be a 7-year transition period. And then the RRC is also going to have procedure logs and application forms, et cetera, you know, more paperwork. It's anticipated that programs are going to be able to apply at the beginning of 2015. Because this is a new residency, site visits are going to be required. That process might take up to 6 months or more. So it's hopeful that the first programs would be accredited by the end of 2015, which means that then students would participate in the match of 2016, okay? And if the first programs are accredited in 2015, then the last graduates of the 1-year fellowship program would be 2022. So, and again, it's anticipated that the people, you know, at the beginning are going to be the more senior people. So we actually might have our first graduates of the new IR residency as soon as potentially 2017 if we've got the senior level people. So what does this mean? Well, in terms of recruitment, the SIR is, you know, I mean, people don't know, or students may not even know about diagnostic radiology. Well, they probably don't know about IR. So they've been doing a lot of recruitment. The resident and fellow section of the SIR actually has its own webpage, and they have a medical student council, which is student run. They've actually, in 1 year, increased the number of student SIR members from 134 to 442, which is a 281% increase. They've also are promoting not just radiology interest groups, but specifically IR interest groups, and they've got a cookbook for anybody who wants to put one together. And they're talking about medical student symposiums, you know, on the weekends, those types of things. What's going to be the impact of all of this? Well, again, they need to educate students and make them aware. So there's going to be a push for IRs to be giving lectures during the preclinical years. There's going to be a push for IR clerkships and rotations, and maybe some of those rotations might even be part of other specialties, like 2 weeks of IR during surgery or something like that. And, I kind of wonder, will this help, or will this actually hinder or possibly compete with all of the efforts that, people are doing in terms of increasing imaging education in the medical student curriculum? We'll have to wait and see. The other is mentoring. I mean, we're already, as awareness increases, you're going to have students who are going to be interested. And how are we going to advise those students who are interested in applying in diagnostic radiology residency? We have, just for those who don't know, there's a wonderful residency guide that's put together by AMSR, available on the website. Those that are interested in IR, what are we going to tell them? And there probably will be lots of students who are going to be interested in applying to both programs. I think the important thing is that we need to collaborate. We need to work together in terms of the IR and the DRs, and work together because there's strength in numbers. And also, it's just a reminder, we're all radiologists, at heart, and that's important. There's a number of stakeholders, and I think that's very important. But I also put it out there is that what can we learn from the SIR Medical Student Council? For example, how many student members do we have of AUR and AMSR? It's free membership, just like it's free membership to SIR, but I don't know if we really know that, or do we even know that for free members, student members of RSNA, of Rankin Ray, of ACR. And, if a student is interested in diagnostic radiology, what is the primary group in order for them to become involved? I honestly don't know. And then what can we do to increase student awareness? Because as everybody knows, the number of unfilled positions in radiology in the last 5 years has certainly increased, while the percentage of U.S. seniors who are filling those positions are decreasing. So these are the resources if you want to find out more. And to summarize, IR is a new residency recognized by the ABMS. It's one of 4 certificates, and unfortunately, the final version of the program requirements probably won't be out for another year, so everything is subject to change. And here's my email if you have questions or you want to converse with me. Thank you.
Thank you. I think we'll hold all the questions for the end. And let me point out with Dr. DeSalvo that in the same way that the AUR booklet decided to transfer me to a medical school, which I'd never worked, they also decided to publish the not quite accurate title of his talk in the booklet, so you can drop the last few words in the title, and this is the appropriate talk and the real Don DeSalvo.
Thank you. The view slideshow is there. Let's see.
And then it's just the right left button.
Okay. Yeah, I just need to get the view. I'm sorry, I just don't know which is the view slideshow. Oh, I hear. I think I do this center thing. Views. Go to slide.
You can't do it from this,
Okay.
because this would just give you next.
Oh, it's going.
This would give you
Oh,
next. Your full-
excellent.
your full-
Oh, perfect.
Your full screen.
Okay. Sorry. Thank you. So basically, yes, I basically wanted to start by making a brief review of where ultrasound education is and point out some recent trends, some of which I think could be a little bit disturbing and I think is a bit of a wake-up call for us, and to just briefly touch on what the AMSR contribution has been, and then mostly to talk about this collaborative model that we came up for integrating ultrasound into the curriculum at Harvard Medical School. So I think anybody who does ultrasound is aware of the utilization explosion. Certainly ultrasound has widespread utility. Anybody who does it and has looked at our experiences with cardiology and OBGYN realize that. I think also with the increased concern for radiation exposure, we've seen a real increase in the demand for ultrasound and some decrease in some of the other more specialized modalities. I think that the miniaturization technology has really enhanced the diffusion and dispersal of ultrasound into radiologists as well as non-radiologists. And I think coupled with that, there's been really aggressive marketing to non-radiologists. And this leads to the sort of potentially controversial point of care ultrasound. I think almost anybody who does ultrasound is aware of this. In case you aren't, it's basically ultrasound that's brought to the patient and performed by the provider in real time. And this is from the article by Moore and Capel in New England Journal of Medicine. And this has come from that article and talks about all of the specialties that are basically embracing this miniaturized ultrasound and all of the applications that they're doing. So what I think is happening is that ultrasound medical education is being driven essentially from the top down. It's coming from clinicians, many of whom, as I said, are non-radiologists, who are then trying to train and teach their fellows and residents in order to attract more of residents and fellows. And then this in turn is being trickling down to the medical students. And this is certainly backwards from the way that I think most of us like to think about where education should be coming. And I can point to some examples in my own backyard of this. I think all of you sitting in here probably can think of similar examples, but the most blatant one is the Emergency Ultrasound Fellowship that was started at Brigham and Women's Hospital in 2010. It is a 1 to 2 year fellowship, has 4 attendings, ER attendings, and basically the entire time is spent in performing point-of-care ultrasound in the ED. They have a simulation center, which was primarily used for training for problems with acute care and mannequins, and this has now been carried over to actual ultrasound simulation. And they've expanded this now, and they have an international ultrasound outreach, and they send these fellows broadly to do this training. Mass General has its own rheumatology MSK ultrasound division where they're using ultrasound, and this is run by a rheumatologist who actually did have an imaging fellowship, but just a short one, but is primarily a rheumatologist. And right across the street of pediatrics, this is an editorial that appeared, bedside ultrasound of pediatrics, and they give you 2 scenarios. I'll just read them briefly. In the upper left, in 2002, overnight shift in the pediatric emergency department, room 1, a fellow is attempting to place a central venous catheter in a 5-year-old boy with presumed septic shock. She's been unable to locate the femoral vein. In the next room, they have a 7-year-old trauma patient, tachycardic, poor perfusion, and abrasions on the chest. Team is calling for a portable chest radiograph. And then a resident taps you on the shoulder, can I present a patient? A third patient, a 15-year-old girl with lupus complaining of chest pain, who's ill-appearing, tachycardic, and short of breath. I've ordered labs and a chest radiograph. Now move forward 10 years, and this is what is already happening. The first case, the central venous catheter is a bedside ultrasound is performed by the fellow in the ED who's able to get it in. In the next room, the 7-year-old trauma patient with poor perfusion and abrasions. They've already done their focused assessment with sonography. They find free fluid in Morrison's pouch, no pneumothorax with ultrasound, and they move on to ask for a computed tomography. And the third case, the resident says, I've already done the bedside ultrasound. There's a pericardial effusion. We're moving on to the next step. So some of this is wish fulfillment, but some of it is actually being performed. If I just look informally at ultrasound medical education, there are approximately 25 schools that have some form of ultrasound medical education, and I've listed them there. And some schools have even gone to having a 4-year ultrasound curriculum, and I've listed a few of the places. And I wanted to point particularly to the University of South Carolina. This is the picture, either, depending on how you look at it, of the devil incarnate or the savior. But this is Richard Hoffman, who up until very recently was the dean of medical education. He is a rheumatologist by training who has embraced this whole process and has designed a very impressive 4-year curriculum. I've met the gentleman. He's very charismatic. He's very well organized. And I've just put up the reference there for anybody who wants to see what he has established. It is quite impressive. And he is the founder of this organization, the Society of Ultrasound and Medical Education, which again is primarily non-radiologic based. I'm not a member of this group. I don't know any, so I can only speak from what I see from the websites, but they certainly have very impressive learning modules. They have joined forces with the AIUM, and last year at AIUM, the pre-course convention was a full day of this topic of ultrasound in medical student education, and there was actually hands-on workshops for both medical students and residents This is, again, was run by a collaboration of radiologists, but primarily non-radiologists. So this is some of the face of where the education is going. I wanted to also briefly point out what our response has been, and AMSR, in conjunction with the Society of Radiologists in Ultrasound, has come up with a national ultrasound curriculum. And I'm happy to report that it is available now in Ultrasound Quarterly, and hopefully will be coming soon to the AMSR website. And I won't go into this further. Tomorrow I'll be discussing this at the AMSR session on education in the afternoon, but I would encourage you to have a look at it if you haven't already had a chance to. What I'd like to do now is mostly turn to the pilot program that we devised, and this was a second-year curriculum course, a physical diagnosis course, run last in the fall semester. The class size was 42. This is the way Harvard does their educational system. There's one of 3 hospitals, so this was at the Brigham and Women's site. And this is normally a 31 half-day sessions, and we devised 4 ultrasound modules taking up between 90 and 120 minutes each. Our goal was that ultrasound was primarily to reinforce the principles of the physical examination by demonstrating in real time anatomy and physiology. We wanted it to be learner-centered and relevant, and there had been some previous efforts and false starts that I'll tell you about, but the goal was to get ultrasound probes into the student hands as the most compelling way for them to learn this material, and the students would be examining each other as they do for a normal physical diagnosis course. I run the radiology clerkship. It's a required clerkship at Harvard, and I've always had hands-on ultrasound there. And the students, while they like it, generally the feeling has been, well, this is too little, too late, too little pathology because they're just examining each other. And by the time they get to us, many of them have already gone through the major clerkships. Another false start, an ultrasound program was actually introduced into the first-year curriculum, actually into the histology course, by the ED group, unbeknownst to any of us. These were 6 sessions, large group demonstration, and the student feedback was very negative. They said it was complete, it was an intrusion, it had interrupted their course. So the next step was basically getting all the stakeholders in the same room. And so we met over the summer. I talked to the course directors who ran the course. They were interested. We had both the clerkship and the residency program directors on board in the room, and as well as the emergency room physicians and the Department of Rheumatology. We decided to use the Stratus Center. We already had the center there. That was great. That was coming from the ED group, and the portable ultrasound units would be coming from the MGH group. So as I said, there were 42 students. We wanted to keep the group small, so we had 4 to 5 students in a group, each group centered on 1 machine and 1 tutorial leader, so that meant we needed 10 tutorial leaders and 10 portable units. These are the players, and I wanted to give a special thanks to my radiology colleagues, Drs. Clark, Dr. Durfee, Dr. Smith, and really a kudos to our residents who stepped up to the plate and at all levels volunteered to become tutorial leaders. The emergency group is by Drs. Rempel and Stone, the course directors, Dr. Saldana and Kumar, and then the rheumatology and endocrinology folks as well, and all of them had included their fellows in residence. So we decided on basically a plenary session, 15 minutes, basically using a demonstration, actually showing the students what we wanted them to see in an introduction using a large screen format. But the goal was to get them to do hands-on scanning, and that was the bulk of the time in these small groups, and they were all being supervised. And then after this, they would go on to wherever they were going, to their clinic or to their hospital, to do their actual exams that correlated with what we were doing. So the first module was just an introduction to ultrasound, concentrating on the physics, the probe image orientation, the basic controls, and we started with the neck, which was the easiest. Next module was abdomen, looking for liver and spleen edge, kidney motion, and the great vessels. The third module concentrated predominantly on the thyroid, and we had the endocrinologist and the ultrasound student side by side. First, they would attempt under his guidance to find, let's say, the right lobe, the left lobe, the isthmus, and then take the probe and confirm whether they were right or wrong. And then the fourth module was musculoskeletal, using the shoulder physical examination and the sonographic examination side by side. So here's just one of the orienting slides. Students feel much more comfortable with the CT, so we put that up and show them how the correlate is with the ultrasound just to get them started. And then these were some images from the shoulder and the musculoskeletal. These are just some of the actual images from the session. Here we can see it, one student holding the probe, the other two students observing, and then the tutorial leader at the front there helping to sort of guide where they are with the ultrasound. And here's actually one of the ED fellows, again, sort of guiding the students as they go through the neck examination. So the other important benefit is that this fits beautifully into the resident as teacher curriculum. Radiology resident participants were briefed prior to each session. The residents were able to be observed because we had enough staff and residents serving as primarily tutorial leaders that were able to circulate around the room and observe them as they were teaching the small groups. We had a checklist created by our program co-director, and afterwards we were able to debrief the residents. Caveats: students were warned about intrinsic variability, the chance for unexpected findings, and there was actually an incidental thyroid nodule that was referred for formal evaluation, but fortunately was benign. And they were also confirmed that sonography was not entertainment, but a diagnostic modality. And I think, you know, the reactions we saw were just amazement. They loved seeing the real-time motion. Also, it was interesting to see their frustration with the hand-eye coordination needed, and I think it gave them more respect for the modality, and they really wanted to have more exposure. So this was a pilot project. There was no formal testing of the student knowledge, and we weren't comparing students between different groups that either had it or didn't. We just had an informal survey, which was highly positive. But we've gone on now to apply for an IRB to allow for actual testing and comparison between other sites. So in conclusion, I think miniature ultrasound technology is increasing the utilization of ultrasound across many non-radiologic specialties. As a result, the demand for medical student education is really growing. There are many ultrasound educational organizations, some primarily created by radiologists, but others that are not, but who utilize ultrasound. I think radiologists really have to maintain an active role, and this is really where we need to step up to the plate. I've touched briefly on the National Ultrasound Curriculum, which I said I'll have a chance tomorrow to discuss more. And this is really just a model for a collaborative effort between radiologists and other clinicians as one approach to try and fill this need for educational needs. I think coupling the ultrasound with the physical diagnosis really will maintain student interest, and using the interdepartmental collaboration allows you to meet the heavy manpower needs in order to keep the group small and allow for hands-on involvement. And finally, it really does help with the resident as teacher curriculum. Thank you for your attention.
This has actually become a fairly bloody battlefield, so I'll be expecting some interesting questions. Speaking of interesting questions, I'm often greeted with a parade of students of all years coming to my office going, well, what's radiology going to be like in 5 or 10 years? And my residents heard one very interesting version of what that might be from Dr. Hooser on Monday, and he was pretty rosy, but so I'll be interested to see what Jason Nadich has dug up.
Well, thank you. It's an honor to be here, part of this distinguished panel. This is a very difficult question, and I've had many difficult conversations recently with our medical students and residents, and I'd like to share with you my thoughts, and I think we could have an interesting dialogue afterwards. The objectives of my talk are to identify medical student and resident concerns about the changing economic landscape, to describe the current job market and assess current projections about the short-term future, and suggest ways to create a positive message to address the legitimate concerns regarding the future of our specialty. This is a picture of the incoming class of the Hofstra North Shore LIJ School of Medicine, where I work. We started a medical school 2 years ago, and I've had the privilege of getting to know them very closely because they are such a small class. They are very bright, they're educated, they're motivated, they're compassionate, and I think the future is very bright as long as we can get them to go into radiology. Now, like many of you, my job in recruiting them into our residency has become increasingly challenging. If you look, this is data from the National Residency Matching Program, and as was alluded to earlier, over the last 5 years, we've witnessed a sustained and dramatic decline in the attractiveness of radiology to medical students if you use positions matched by U.S. grads as a surrogate for attractiveness. In fact, if you look at the numbers, in 5 years, we went from 84% to only 69%, which is dramatic to say the least. 42 programs went unfilled, and for those of us who did fill, most of us had to go deeper in the match than we have in the past. So why is that? This is a table I put together from a survey that the AAMC does every year of medical school graduates. And they say that they choose the field to go into based on their own personality, interests, and skills, as well as the specialty content, which I think is appropriate. However, I don't think that's changed in the last 5 years. Work-life balance and family plans, I can't think of any other specialties more attractive than radiology, so I don't think that's the difference. Income expectations, if you take the group that ranked that as moderate or a strong effect on their career choice, that's about 50% of the medical students, and we'll talk a little bit about the effect that our current economic situation is having on them. But I also want to highlight, and I'll come back to this, that the collective role of moderate and strong influence of role models at 80% dwarfs any economic interests of the students. And I think that's the area where we can combat the loss of interest in radiology. Probably can't read this, and that's part of the point. This is from the ACR outlining the number of cuts made to radiology reimbursement since 2006. It's no secret to you that we're under assault, and I don't expect that to diminish. I think fee-for-service is a losing proposition, and we need to transition out of it immediately. So I am an inherent optimist, I will freely admit, but it is pretty difficult to be optimistic sometimes when we think about how radiology reimbursement is going. But I do think that we need to bring information to the table when we talk to the residents. Nobody likes to talk about money. We're in academics because many of us think money is beneath us to talk about. But the truth of the matter is medical students take on a fair amount of debt, and they work really hard to get where they are, and it's important to them. And I think we need to address it. If we don't talk to them about it, they're going to get their information elsewhere, and a lot of the information out there is bad information. So this is from Medscape, from a compensation survey from 2013, and it shows despite our salaries coming down a little bit, we're still at the top. We're twice what family practice and pediatric makes. Money is not the reason to go into radiology, but it's really hard for anyone to make the argument that you shouldn't go into radiology because you can't make a good living. I think if you look at the history of economics, there tends to be a reversion to the mean. We have experienced a bubble in radiology. I fully expect the differences between the highest compensating fields and the lowest compensating fields to narrow. I do think specialists will continue to make more than generalists. Where it lands, I don't know, but this should not be a factor in why we decide to do what we do for a living. Going back to 2011, there was a wonderful article by Ancelotti and Howie Foreman on the relative attractiveness of radiology residency. And they used the fill rate of the match as a surrogate for the attractiveness to medical students of radiology. And they looked at help wanted ads as a surrogate for the job market. And you could see that the attractiveness to radiology residents tracks almost identically to the job market with a 2-year delay. I show this slide because this is the relative attractiveness of radiology versus internal medicine. And this slide affected me profoundly because I trained in the early 90s, and I know what it's like to have gone through medical school during a time when the dean was telling you to go into primary care, that it's all about internal medicine, radiology is dead. And I just thank God that I didn't listen. I followed my heart, and I'm grateful to this day because I love what I do, and that's the advice that I give to the medical students. These things are transient and hard to predict, and I think you just have to follow your heart. So my advice to medical students is don't be influenced by the job market. Just as with financial timing, people are really bad at it, right? People tend to buy at the wrong time and sell, right? They wait until the market crashes and they sell, and they buy during bubbles. This is no different with job market timing. And that's why there's a 2-year job lag between, by the time the residents are actually the medical students are making their choice, the job market's already started to rebound. The other reason is the horizon's way too long. It takes 6 to 7 years between the time they decide to go into a career and the time they get their first job. There is no correlation between the job market 7 years from now and what it looks like today. So I tell them, do what you love. If you're passionate about your career, you'll be successful and you will be happy. And extrinsic rewards are secondary. The other thing that I like to tell them, which touches upon what you heard earlier about ultrasound, is don't be afraid to compete. Many of us felt that radiology is a birthright and that only we can manage imaging. And I don't like the terms turf war. We don't own imaging. My belief is that we do it better than everybody else. They spend 3 months training, we spend 6 years training. Just do it better. If you are able, available, and affable, you will outcompete any other specialist. So I really don't, I encourage you to say the same things to your medical students and residents. And don't be afraid of competition, just be confident. The other thing I do is I try and talk to my faculty about being role models. It doesn't matter what one person says. It matters what the whole department says. So we engage the medical students from the very beginning in year one. We teach them, we actually teach ultrasound to the medical students in the first year, so they don't learn it from the ED. I tell our faculty, be careful what you think. I mean, everyone has heard this before, but be careful what you think, for your thoughts become your words. Be careful what you say, for your words become your actions. Be careful what you do, for your actions become your character. We are always on stage. The medical students watch everything that we do, everything that we say. And a lot of our faculty, like a lot of your faculty, feel sorry for themselves. They're worried about the fact that their incomes are going down, there's less job security, we're working harder than we ever worked before. But when you think that way, you say dumb things, and you act in a way that's selfish, and people pick up on that. And if that's the way we're perceived, no one's going to want to go into our field. So among other things, we assign formal mentors to our medical students, one-on-one mentors, people who really know how to be mentors. And we get them involved in research, and we teach them clinically. But the other thing that we do is we socialize with them. So I had them over for a dinner recently, just the mentors and the medical students who had an interest in radiology. And probably the best thing I did is I asked the faculty members to go around the table and just speak extemporaneously about what they love about radiology. And these were just a few things that they said, and it really doesn't matter what the reasons are. The room lit up when people started talking about what they love about what they do. And it actually made us feel better about what we do. And I think this is something that I would encourage you all to go home and do in your own institutions. So what about the residents, the poor residents? The medical students still have a choice, but the residents have made a decision, and they're worried. They may talk to you about it or they may not talk to you about it, but they're on Aunt Minnie and other chat rooms talking about this. They are worried. There was actually a New York Times article that came out that sent a storm through the New York area, and I don't know if it affected everybody else, but there was a program in the Bronx that closed down, and everybody was really afraid of what was going to happen to radiology residencies and residents' future job potential. A survey of the chief residents basically said that 95% of chief residents felt a little worried about finding, at least a little worried about finding a job. These are the chief residents. These are the best of the best. 95% of them are worried. 60% are willing to accept lower salary, 50% willing to accept less vacation time, and so on. We have to face that this is demoralizing. No one wants to go through training to then have to take these kinds of concessions. I think the way we talk to them is with data. So there's a wonderful study that comes out every year. Dr. Bluth spoke about this yesterday in the ACR workforce study that tracks the number of available positions. One piece of good news is that the previous survey thought that there would be about 1,100 jobs available, and in fact there were 1,400 jobs available. So perhaps this survey underestimates the number of jobs that will be available. But the range of jobs available projected for the next several years up to 2016 is around 1,400 to 1,500 jobs, which is not a lot considering we have 1,200 people looking for a job every year coming out of training. So the survey suggests their conclusions are that all finishing residents and fellows should have employment opportunities, but as previously stated, these opportunities may not be in the geographic area or the type of practice that the individuals seek. Good news, bad news. The good news is they should have a job. The bad news is they'll have to make compromises. The real question is this temporary? Because I think most people are willing to make a sacrifice early on in their career if they know that this too will pass. So people often ask me, they say, as a chair, what are you going to do about it? Are you going to decrease the number of residency slots? Should we decrease the number of residency slots? And I think this is one of those areas where, are we training too many residents? I think it's one of those areas where Yogi Berra got it right. I think that it's very tough to make predictions, especially about the future. It seems that radiologists, one of our favorite pastimes, is predicting do we have too many or too few radiologists. And I'll just give you a brief history of the literature. In 1973, it was suggested that we had too many radiologists and that we should decrease the number of spots. It turned out that was incorrect because they couldn't foresee the implementation of CT, MR, and ultrasound and what that would do to demand. In 1982, it was predicted that there would be a 34% surplus by 1990. Of course, that didn't happen either, and in 1990, there was a surplus. We get it wrong the other way. In 1990, we predicted that we would have a surplus with that we'd have a shortage with greater than 5,000 radiologists too few, and it turned out that we had a big surplus in the mid-90s. This is my favorite, and this is not, I'm not impugning anyone who did this research. I mean, because it's just impossible to predict this stuff. It was predicted in 2002. The consensus was that we had too few radiologists, to the point at which there was an article written on not whether we should do something, but what the best way to handle this was. Should we increase the number of residency slots at existing programs, increase the number of programs, or just shorten the residency? But we had to do something fast. Yet in 4 short years, we were wrong. And by 2006, the shortage had eased, and it was largely due to a productivity gain, largely because of PACS. So if you look at history as a guide, just as I was telling the medical students before, we're really bad at this. We're bad at predicting, and when people act, it's usually too late. If you look at the trough there, that's the last period that was similar to this of managed care and healthcare reform. And what tends to happen in a time of great change is people get scared, and when they get scared, they get paralyzed. So they stop hiring. People just don't make the changes that are needed to make under ordinary circumstances, and that can only go on for so long. And once people adapt, that pent-up demand usually rebounds, and that's exactly what happened following the last trough. I don't know if that's going to happen again, but it's reasonable to assume that it could. So I think we need to explain to our residents that part of what we're seeing in the job market is cyclical, because of delayed retirement. People didn't retire because of the financial downturn in 2008. The market's starting to recover, or it has recovered. There's reason to believe people will start retiring. People didn't hire because of uncertainty, and we could have a rebound. But part of this is structural. I do think we need to be honest with our residents and let them know things have changed. This time is different. We've experienced enhanced productivity, and we've experienced decreased utilization for the first time. Utilization has gone up astronomically over the last decade until the last 2 years, where we finally have started to see it come down modestly. It's only gone down by about 2%. But decreased utilization is real. It's because of utilization management from radiology benefits management companies, as well as the advent of clinical decision support, fears of radiation, and high deductible health plans, which put the risk on the patient. So I think we need to have reasons to be optimistic and talk to our residents about what are those reasons. I do think there's reason to believe there'll be increased demand. More patients are insured through the ACA. The population's getting older and sicker, and there's a potential decline in self-referral. This is the biggest wild card. There's talk finally about legislation to stop self-referral because it's a huge economic drain on the government. And I also think that more and more we're seeing managed care plans with complex contracts that make us prove our quality. I think the days of 0.3T MRIs in physicians' offices may be limited. I think there's a potential that we'll also see a decreased supply of radiologists. You don't hear people talk about this terribly much, but our workforce is pretty old. 7% of our radiologists, my cousin included, 7% of radiologists are over 65 years old, and another 22% are between 56 and 65. These people will eventually retire. And if reimbursement continues to go down quickly enough, my prediction is they'll retire pretty quickly. So my advice to residents is think differently about this. I think we have to address all their concerns, but the biggest thing we could teach them is that they're thinking about it the wrong way. We shouldn't be thinking about volumes and jobs the way we used to, and reimbursement per procedure the way we used to. The best way to predict the future is to create it. They are coming through medicine at what I think is the best time to be a doctor. Our whole healthcare system is transforming. I'm part of a very large integrated healthcare system that is in the midst of transformation, both in the way that we deliver care and the way that we're reimbursed. We're moving from volume to value and from fee-for-service to all kinds of complex risk-bearing arrangements. And I will tell you that this has changed the role of radiologists in our organization, and I believe it's only the beginning. I hope that we have less volume. I don't see it happening. I don't know any radiologists who don't have enough work to do. I mean, most of us who have jobs are incredibly busy, and we would be served well if we stopped trying to run faster and faster on our treadmill going nowhere and try and focus more on the value that we can add, largely in non-diagnostic work. Utilization management, we are going to be at the center of cost management. When we go from fee-for-service to a capitated environment or any other kind of shared savings model, we go from a revenue generator to a cost center overnight. And we are crucial to our CEOs to try and maintain profitability under these new payment models. Utilization management is going to be key. You only want to do tests that are necessary, and you don't want to do tests that are unnecessary, but you also don't want to deny people the care that they need. Radiologists are in the perfect position to do that. Quality assurance. We need to spend a lot more time defining quality. I think we've done a terrible job. One of the reasons our reimbursement has gone down is because it's very hard for any of us to say what value we add. This is a big area of research as well. Radiation safety, obviously, technology supervision and education, equipment selection and optimization, regulatory oversight. You can go on and on and on and on. We don't spend enough time doing this because we're too busy reading cases. So if you look at the transition from fee-for-service to global risk, there are lots of steps along the way. I'm not going to go through each one of these, but what I can tell you is we have about 25% of our contracts are now outside of fee-for-service, and within the next 3 years, it's going to be over 50% outside of fee-for-service. So the future is here, and we need to tell our residents that. This is the holy grail, I think, of the future of being able to fund our education and research mission. Fee-for-service is a losing proposition. So we, like many other health systems, have formed our own insurance company. We now have our own products on the health insurance exchanges. What we all have to do is expand the pie. Everyone in economics always likes to talk about expanding the pie. If we have to fight with each other and divide a shrinking pie, we all lose. The opportunity is taking the money back from the healthcare insurers, which is just waste. Cut the middleman out, take that money, and then put it towards the healthcare we actually want to deliver, research and education, and we're in the process of doing that. Finally, I think there's an enormous opportunity in healthcare services research. I think this is a great time to be a resident. If you don't have a PhD, if you don't have a history of doing benchtop research, in the past you might not have been able to do meaningful research. You might not have been in a position to do pulse sequence design. This is something that's readily accessible to most radiologists, and I think it's critical to the mission of what we do. We need to get residents involved in cost effectiveness research, comparative effectiveness research, and outcomes research. So in conclusion, I think medical students and residents are justifiably apprehensive about the future. The rapid pace of change and the number of variables makes predictions tenuous. And I think we have to be honest about that. We need to let people know that that history has shown that we're usually wrong, and they shouldn't be too short-sighted in their beliefs, and they should follow their heart and do what they want to do. There are many reasons to be optimistic about the future, and I believe that our jobs will be less volume-driven and more value-driven, and therefore more satisfying. Thank you.
Well, through absolutely no input on my part, these talks are sensational. And along those lines, we now have Christopher Strauss, who will be wrapping up the session with his white paper, some of which you heard a few pieces of this morning, but this ought to be very interesting.
Well, I'm hoping it is. That's a hard act to follow. Actually, I want to hear more about the last one. I hope everyone can hear. Sometimes I have issues with microphones and weird feedback, so if you hear that in the back, let me know. But overall, what you're going to be hearing a little bit about is this white paper, which was alluded to last year, and a combination of events that have happened with the ACR, but let me try to move things forward. Let's go. Why aren't you moving? Oh, there you go. First of all, I have nothing to declare other than an extreme interest in medical student education. But overall, what you see in front of you is the title page, the proof, the final proof of the medical student radiology education, a summary and recommendations from a national survey of medical students, medical school and radiology department leadership. I can't even say it, it's so long. Unfortunately, this is the shorter title, actually. But overall, this is going to come out. I thought today, literally 2 hours ago, the JCR, the new month was just released. I ran up to my room, and it's not out this month. It's going to be out next month, I hope, maybe the month after. But this is the final proof. But we're published. At least I'm going to make that claim at this point. But a little bit of history for those in the room who do not remember me hassling everybody with phone calls and emails saying, fill out your surveys. But I'm going to give a little bit of history of what happened back in 2012. The ACR convened a task force on medical student education and radiology. Very bland title, but it basically was made up of multiple departmental chairs, largely. And they pretty much said, ooh, we want to study medical student education. And we're going to go to AMSR and see what they know about if they can assist us, because we really don't want to write the paper. We want their help. So they turned around and pretty much said, what are the standards? And of course, what was our response? We have absolutely little knowledge. We pretty much, what did we know? We had anecdotal data, information essentially from our own AMSR and AUR members, which after we started looking at the various lists and enrollments, it was about 50% of the country. So it was sort of like the moon. There was a backside. We didn't know what was going on in the other half of the country. And we pretty much decided in the end that we didn't know what. We had squat. We just basically had an empty box. So we had some background understanding, some observation, pretty much extensive variability across the entire country in various different programs. But we really started, of course, asking additional questions, as we all like to do in academics, and that is, what are the prevailing trends? Where are we headed to help predict the future? Where are we going with this so we can better advise not only our AMSR and AUR members, but also our students and colleagues? So, examples. What were larger schools doing relative to smaller? Were they teaching differently? Were different programs on the East Coast and the West Coast different than each other in the middle? Or private versus state schools, et cetera. So basically, in the end, we realized we had to do a survey. We ran down the proverbial rabbit hole. We sort of like thinking fast, and we struck a deal with the ACR saying, if you want us to work with you, which we would love to, we pretty much said, we need money, more money, and lots of money. And they pretty much said, we've got money. And so they ended up funding a comprehensive survey of all schools throughout the United States, pretty much utilizing professional data collection and techniques. It took several months to create this horrendously long survey that many of you, I'm sure, remember. But we had a joint goal, and that was to sit down and co-author this positional white paper, which you saw the cover page, and it would pretty much summarize the current status of medical education and imaging education as we know it in 2012, and most importantly, hopefully provide and promote a more uniform and relevant educational model for many of us to work off of as we move towards the future. So long-term AMSR value, pretty straightforward. We pretty much wanted to document what was the current educational methodologies and resources. That's easy enough. But again, baseline information. We really needed quality data on which we can actually sit down and do more research, find that value that was just alluded to in our last talk, and identifying effectiveness measures, because we all have great ideas, we think they work, but we really were having a harder time actually identifying what really was effective. Also allowed comparison, so different programs can actually sit down and actually go to their chair and say, look, I made this change, but I now compare it against this national standard, and that wasn't really able to do previously. And lastly, and I think most excitingly, really was the potential nationwide, it should be nationwide, policy changes that we can now actually go forth and actually with these numbers, this hard data and greater understanding, we can actually now put pressure on the ACR and other organizations, RSNA, et cetera, and actually say we need some of these changes in our program for various reasons. Time course, pretty straightforward. Survey creation, submitted the survey in the fall of 2012, got the data back, and 200 and some odd pages of condensed data was actually provided over the winter and spring. We sort of went running through and analyzed it, wrote the paper, finalized that version in August, had a big deadline because we had to get it in front of the ACR board for their fall meeting. It was reviewed and ratified at that time. And from that report, we were able to actually summarize it, create the white paper that you will read, along with a great deal of extra data in the various appendices, which then was revised by the JCR and accepted in February. What we were excited to and be able to report, as I said, not only is 200 pages condensed down, captured a statistically representative, balanced view of the U.S. allopathic medical schools. I was very excited when the statistician said, oh, it really is. It works. It's really for class size and geography. You pretty much have covered the country as we know it, and that was gratifying. But it also showed something else right up front, which was sort of a little bit more startling, and that was the overall uniform low percentage of radiologists engaged in medical student imaging education. It pretty much stayed relatively constant over that time period. So as all this imaging has been increasing, we're not making up for the difference. It's been going off to other specialties, and I think we obviously talked about ultrasound among others. This is regardless of school size and faculty size as well. So this was an interesting revelation. The publication is very simple to run through. Overall, 3 parts. There's the survey results, followed by recommendations, and we opted to include an action plan. We really wanted to sit down and identify potential steps that each of us individually can actually react, because sometimes you don't quite know, what can I do? How can I make this better? And so actually for this ease of the presentation, I'm going to combine the recommendations and action plans together as we move forward. But overall, it really summarizes the current state of the state. So what's out there, it demonstrates to the best of our understanding of what's being taught currently across the country, where, how, et cetera. But most importantly, the data was correlated with the known literature. So we were able to actually give you, hopefully, that solid platform of which all of us now can work off of for research and, again, optimizing our curricular changes. But most importantly, we also wanted to identify major barriers to these potential changes, which you'll hear a few about in a second. So we sought validation, essentially a nice fancy way of saying the same thing, and to promote better understanding, mostly by comparing the perspectives of two distinct groups. What you're going to see, and when you read through the paper more carefully, you'll see that we actually surveyed both radiology chairs and or designated individuals that were identified as the education guy in the department, or gal, I shouldn't be, that's using that in a sexist way, and most importantly, we interviewed and surveyed deans of medical schools and or their curricular heads, because we really wanted to have two distinct surveys of which many of the questions were actually identical or designed in such a way we can actually then compare the two, so we can identify where they were thinking the same, where they were divergent, and most importantly, where can we place our efforts and energies in the near term to actually bring about the greatest amount of change and ultimately success for our own specialty. So we were highlighting the disparity between these two key groups, and ultimately, as it says with the yellow arrow, identify possible methods of improving our educational system overall. Survey highlights, I'm going to hit 5 key elements that were really sort of the cream off the top. There's plenty of other data that's in there, but these are the ones that I would say were relatively either shocking or something that's relatively obvious. So some of this data will seem rather self-evident. Hey, I knew that. You're not telling me anything I didn't know. Well, we now have data that actually shows it, so we can actually reference it. And most importantly, that's the kind of thing the ACR needs if we're going to go to try to impact government and other larger organizations. But right off the bat, this one I think is pretty straightforward, and that is the agreement between medical schools and radiology departments, that'd be the chairs and those of us colleagues, identified that there's an increased need for medical imaging across our systems. Well, big surprise. But there's a huge disagreement between these radiologists and medical school leaders in that the latter, that is the deans of medical schools, very clearly and distinctly identified non-radiologists as adequately teaching imaging. This was not debatable, and that's a little bit disturbing. Few schools have required medical imaging education. We have seen numbers before, roughly 1 out of 4 programs across our country have required medical imaging in some format in their 4-year programs, and this was confirmed. There's also been agreement between deans and radiology leaders in that imaging needs to be standardized and vertically integrated into their programs. And this is one of the areas of least consistency across our country. Everybody's sort of creating their own wheel on this one. And that's something I think that all of us can start collectively talking and discussing how can we make changes in that particular area. But ultimately, we need to be incorporating these different elements together, such as ACR appropriateness criteria, which obviously was identified explicitly as being underutilized and of high value. And lastly, medical school deans do not differentiate support for medical imaging between our two entities. So basically, radiologists and non-radiologists, as far as they're concerned, they're one and the same. They don't care whether the ER teaches ultrasound or radiologist. They just want them taught and the students happy and filling out those evaluations saying, I loved it. All right, and that's going to be an important issue. Additional topics, these are just some of the others skimmed off the top. There's many others, but faculty interest, financial support, promotion, advocacy, national curriculum, which we touched on, methodologies, but also the last one, which I find kind of intriguing, and that is at what point in the curriculum is imaging currently or optimally being taught. These are other areas that we focused on, and as you probably know, we're shifting things a little bit sooner, but this was validating those concepts. The resulting recommendations then were 6 in number. We sort of boiled it down and tried to present it in a digestible content in a way, and that is this was all endorsed by the ACR board, as I said last fall. The objective was then very simple. We really wanted to advance medical student educational materials, pretty straightforward, but we really wanted as well to improve the understanding of the radiologist's role in the patient care arena by the non-radiologist. Said another way, of course, and we've heard this before, we're trying to educate and better educate, I should say, those that are becoming our referring physicians, those future surgeons, those future obstetricians. How can they use imaging resources more effectively, and again, stay within those models of efficiency? And who else should be making those decisions? That's us. We need to step to the plate. Well, so the goal was then to keep some of these recommendations in a modular or more measurable fashion. So ultimately, programs on an individual basis could then implement these individual concepts or in combined ways as they could, based on their own options, time, and resources. basically striving for a collective greater effect across the country, even though we each may be doing slightly different versions. So the next 6 slides will basically be these recommendations. So 1, obviously this one's pretty standard, and they will increase in complexity as they go forward, and that is radiologists, we need to formally acknowledge that expectations surrounding imaging are expanding in our medical schools and they're not being met. This is not necessarily understood by all of us, and I think we all just need to get on the bandwagon and just start repeating it. We need to do more. Ultimately, this leads to an action plan, pretty simple. Increase exposure to medical imaging by radiologists. We need to step up to the plate. Baseball season started. I immediately say, get up, grab your bat, get to home plate, and start swinging. We need to actually play the game, or we're just going to have trouble. We also then have to support and identify our colleagues and radiologists who are interested in teaching. How can we do more of that? 2, radiologists must be identified as the go-to faculty for teaching medical imaging. And this is obviously, in their eyes, one of the bigger areas that's a little bit tougher to capture. And I think with more enthusiasm and other things that have been touched on by our prior speakers, we can do this. So we need to ensure that fundamental imaging and education is taught by radiologists. It's pretty straightforward. But you need to identify opportunities where students can directly observe us. And I think the whole radiology and sitting back and observing is relatively passive is something that we need to be more conscious, and we need to actually enroll them in a more active fashion into our departments. But ultimately, we need to identify new points of student access and not fall to some of these old traditions, where we really need to be a little more creative on that particular front. 3, we need to shift imaging education to earlier points in the medical school curriculum. There's been more and more published on this in the last several years, so I don't think this is new to anybody at this point, but promoting radiologist and anatomy and other preclinical courses is paramount. And any school and program that is not currently moving in this direction or has moved in this direction, I think you need to make this one of your higher priorities, because it has been shown emphatically that if we capture their attention early, that we really can keep them from learning bad habits downstream that are almost impossible, if not impossible, to remove. So we really have to identify them early, and it's not about turning them into radiologists only, but again, these future referring physicians. So start a radiology interest group. If your school doesn't have one, this has definitely been also identified as a definite positive. We need to increase also digital imaging access. That may be materials that are online, but we also should be probably looking more into social media and other variable programs that even I don't know much about, but we have a very tech-savvy population, and I don't think we're maximizing that particular element just yet. 4, radiology must also provide a uniform message across institutions. This is where we start getting a little dicier, and I was pleased when after the discussion with the ACR, just that we were able to really convince them that this is major and important. I think ultimately we have to sit down as educators and expand, obviously, not only our efforts and the materials, but fundamentally we need to be able to lead and get our students to graduate from schools with a relatively equivalent understanding. So they're not arriving in their internships and highly variable, and again, learning from the first person they talk to, which is not going to be us. It's going to be internal medicine, it's going to be surgeons on their first day of internship. And so we need to do a better job in medical school so that they're leaving those programs with an understanding and appreciation for radiologists and our role in patient care. So example, institute integrated imaging instruction across all 4 years, so catch them early, catch them often. Develop a national core imaging curriculum with both didactic and online materials that we share amongst all institutions, and then hence creates a common platform for all students leaving a program and going into an internship or a residency across the country somewhere else, so that there's equivalent expectations. Institute required radiology, and I mean preferably a clerkship in the 3rd year, again, catch them early, but ultimately we need to stress the extent of direct patient contact and procedures. This was identified very quickly as this is the fun stuff. This is what they want. And we need to do a little bit better about putting maybe not giving them the dessert first instead of the dessert and the vegetables and the better food, but we need to do a little bit more about making sure that they're seeing what is desirable and exciting to them, so we capture their attention. 5, we need to promote the adoption of standardized measures of student competency. I was very pleased this morning at one of our earlier sessions when we did an unofficial poll in this very room and said who's actually using and giving exams in their clerkships or their courses, and nearly everyone raised their hand. It was very nice to see. Long story short, we need to do more of that. The exams show and create a sense of legitimacy amongst the students. It promotes them to actually learn material they might not otherwise choose to absorb. And I'm going to sit there and plug ExamWeb for those who are AMSR members. It is available to everybody who is part of our organization. It is absolutely critical if you're not using exam to create your own exam and potentially use it, because it will drive their performance and whether they do the reading, et cetera. So it's important, I think, to have this national testing on these basic principles. And lastly, 6, radiology chairs must take and must make education a top priority and a valued part of the departmental hierarchy. I'm also seeing a trend. I don't know if I've seen anything published, but I think we will see something soon. Many of you, and I'm sure if I ask for a show of hands, that there's these new vice chairs of faculty members that are overseeing education in a broader sense in departments. These are trends that are definitely in the right direction. If your department isn't currently doing so, you need to talk to somebody who is and see what we can do, because ultimately in the end we need to help our chairs support and promote an educational track for our faculty. It's not based on basic science. These educational tracks are absolutely paramount. Support faculty mentoring and membership in professional organizations such as our own, like AUR and AMSR, because ultimately in the end it's that collaboration. And we keep coming back to that core national curriculum that we need to be functioning and making it modular so that these colleagues of ours and nationally we can reach a higher level. Fundamentally, long-term wins, and that is all this data is available to everybody. As I alluded to, there's not only additional data in the actual white paper, but there are several new appendices that are online only. They're not in the print version. Do jump on, and there'll be additional data available. I will make sure it's available to you if you want to do some further research. There's a lot out there, but ultimately the goal is, and that's this bottom line, and that is the opportunity for us to change the collective non-radiologist perspective of our field is our goal. And I think we need to make sure that larger ballpark view is kept in mind. We're gonna make some real headway in the next few years. Weaknesses, just to touch on, there was, and many of you who took the survey probably remember, there were 3 surveys that were utilized. You will only read largely about 2 in the actual paper, and that is the deans that I mentioned, as well as the radiology chairs. There was a 3rd survey sent out to interns across the country. The response rate was relatively weak, so we chose and opted not to incorporate that formally into our discussion and analysis, but we did use that data to corroborate and to support the other positions that I've alluded to and others you'll read in the paper. So for those who would like to, we can pick that up and create a future study, but I'll accept names and volunteers after the talk. But ultimately, in the end, I wanted to say thank you really to not only the entire team that worked on this greater than 18-month marathon, but truly everyone in the audience and those who aren't present who filled out this very long survey, and obviously for the 3 organizations that are listed below. So much appreciated. And obviously, I think overall we'll all take questions.
Before we open it for discussion, is this online yet?
The paper, I was literally hoping, 2 hours ago, no. It's going to be, I hope, next month. And I'll find out, and maybe over cocktails tonight or tomorrow, or by the end of the week, I'll try to find out exactly where it is in the system. It was supposed to come out this month, and I just didn't, so.
Now, I would suspect at this point the usual moderator maneuvers to encourage you to talk or make comments won't be necessary, but I would certainly encourage you that this is a time to speak to our experts. Yes.
I'm going to report to you from the field. Cut me off, make sure I don't go over 2 minutes. I don't want to monopolize it. So I'm Mike DiPietro from the University of Michigan. I've worked with Don. We've never met, but hello. For the past several years, I've dovetailed the AIUM and the AUR. So I took the red eye last night, and I frantically took notes. The ball game is already in the 7th inning, and we're not on the field yet regarding ultrasound. I would like to, maybe later or something, we can have some discussions. I've learned the tactics that they're using. You said top down. They're really doing grassroots stuff and working up, and it's very, very effective. A couple of announcements. I don't know if you know Peter Arger, who's a wonderful colleague, U of Penn. They just established the Peter Arger Award for Medical Student Education, and it went to Dr. Richard Hopman from South Carolina. And, obviously he's done a lot of great things. Secondly, they did talk about the SUSME, the organization. You can look up what they're doing. I learned that there's a website, www.inkling, like I have an inkling about something.com. Basically, it's guidance for the clinicians about bedside ultrasound and how to do it. And if you download it before the 15th of April, tax day, it's free. After that, you have to pay for it. So if you want to see what they're doing, that's a good thing to look at. Another thing is that if you go to the AIUM website, on June 1 and June 2 at the New York Hilton, there's a big symposium on medical student education and ultrasound. And I can't go, I won't be around, but I hope that somebody, at least to know what's going on. I think it's very, very important. And then I took down notes on other things and talks and that, and I hope we have an opportunity either informally or something to go into some of this, because it's very, very important. So thank you.
Hi, I'm Wally Hooser. In the interest of revealing, I own stocks in virtually every publicly traded company in the United States, and most of those that aren't. First of all, this is a great program. Second of all, the last two speakers in particular, I'd like to just quickly react to. Dr. Nadich and I are exactly on the same page. The problem, it seems to me, is I went into radiology in the early 70s. We were hearing the same things we were hearing now. And by the way, the cardiologists were stealing everything, okay? And then in the mid-'80s, managed care came along, and I remember testifying to the Senate committee to Senator Kennedy, and we were actually told that if you didn't retrain as a primary care doctor, you need, as a specialist, to learn how to sell pencils on street corners. How'd that work out, by the way? In the mid-'90s, we had this same thing. We lead such short lives, we forget that life is cyclic, and you should choose things for what you really enjoy. The situation here, I was in a SCARD meeting a couple of years ago here, and they ran a study and of the chairmanships. And the interesting thing is, what of the things in your program are most critical to you as a chairman in your career? You know what was the last on the list? Teaching, particularly medical students, because it doesn't impact. Why? It's not because they're evil. It's because the presidents of universities want money. Now, why do they want money? Well, if you give the president of a university a choice of an NIH grant for $1 million and a grant from Gates Foundation for $1 million, I will guarantee you they'll take NIH every time. And you know why, right? Because Gates says you get to spend 5% for the tax, but NIH lets you spend 55% or more. So he can build an elaborate office for himself and his buddies and drive around his limousine and draw a $3 million a year salary, okay, while he spends all of his time in meetings and raising money. But what we need to realize, and what it seems to me, is there's chaos coming like there was with Medicare and like there was with managed care, and in chaos there's great opportunity. And all we need to do is realize it and take advantage of it. And I'm retired now, and why I keep coming is because we have sessions like this where people are thinking strategically, not tactically. Thank you.
I really enjoyed these talks. They were amazing. I have a point to Dr. Nadich. That to be specific, a couple of things that I have observed over my career. One is that when I started radiology, I thought it was really important, but it really wasn't. And today, if you think about who goes to surgery without imaging, who has any major medical decision without imaging, no one. Utilization may be down, that's true, but I think that when talking to the students or other people interested in radiology, that's what I emphasize. The other thing is that, you know, as you well know, the residents used to take care of 2/3 or more of the day and night, but today, not so. So therefore, you really need triple the number of radiologists in the long run. And then, of course, you mentioned the graying, well, some of you graying, of the radiologists.
Anyone else? This has really been a call to arms and a wake-up call, and I hope everybody heard the very important messages. Thank you very much.